All right, let's go ahead and get started. Just welcome to Grand Rounds today. Our presenter is Dr. Mark Sell. He completed his medical school training at Chicago College of Osteopathic Medicine and then did his internal medicine residency and rheumatology fellowship at the Franciscan Alliance at St. James Health. Came to Vera, worked in 2019. And for USD, Sanford School of Medicine, he serves as the vice chair of the internal medicine department. He also serves as the division chief for rheumatology as well. And he's going to be talking about evolving concepts in immunosuppressive therapies in rheumatology. So welcome, Dr. Versell.
Thank you. So I'm most excited to get started talking about some of the updates that we have because our field tends to move in big changes in clusters. 25 years or so ago, we had the advent of biologic therapies, and now we're starting to see a new era with things like cell therapies and other types of adapted biologic therapies. Before we get started, I don't really have any financial disclosures or conflict of interest. We're currently involved in some clinical trials for CAR T therapy through Novartis at Avera. But otherwise no financial disclosures. And before I get started, we should really plug the USD library services. I think if you're faculty, if you're tuned in from afar, you're in the room, use the QR code, get the lib key through the USD services. If you're not part of USD faculty, need to be or want to be, come talk with me afterwards. It'd be nice to get you plugged in. Our library services are awesome. I didn't have a hard time accessing anything through the preparation of this lecture because of how easily we can access articles. If you go even have this little widget installed in your extension browser for Google Chrome, this is a Wikipedia page. I just screenshotted Wikipedia. If you go down to the reference, I could pull up any of the PDFs instantly without having to do deep dives or do journal access. You've all seen these paywalls on journals. So it's really worth it. It's free. It's through the USD services. Awesome resources, underutilized. So anyway, I'll jump into my lecture otherwise. Today's objectives, I want to kind of review what we've been doing over the years for treatment of autoimmune diseases, particularly with ways that we use immunosuppressive management through DMARD therapies, biologics, and then move forward to kind of review some of the principles behind that, to then explore other things like our novel therapeutic mechanisms, new types of molecules that are being developed, cellular therapies and what those things look like, and then jump into some of the more common management questions we get, which is probably going to be really practical for a lot of you, hopefully. This is going to focus on what we do procedurally, how we approach things with operations, whether it's orthopedic surgeries or abdominal surgeries. We'll talk about acute illness and the data that is or isn't there for how we manage immunosuppressed patients. And then we'll talk about vaccine schedules and things like that. Those things have been coming up more frequently for us as well, with some of the ambiguity and uncertainty with the shifting landscape currently. So it's always helpful to kind of quickly review, and I won't bore you all to death for an hour over different types of autoimmune processes or different mechanisms that exist, but just to kind of show that there are different theories and different functions that our immune system has, and different ways that those can kind of go off the rails. There are different types of disproportionate immune responses to stimuli. So if somebody gets, for instance, a really bad respiratory infection, a few weeks later gets petechial rashes in the lower extremities, sometimes it's a rebound in your plasmablast or plasma cells producing immunoglobulin levels, like an IgA vasculitis. That's a transient or short-lived thing. So it's an over-robust response to an appropriate immune system stimulus. Cytokine release syndromes can also be classified in this in some cases. Sometimes it's a frustrated immune response, sometimes from prolonged stimulation. A really good example of this that we give our residents and students all the time is hepatitis C, and it's linked to cryoglobulinic vasculitis, right? So your immune system recognizes that you have a chronic virus, tries to produce antibodies against it, tries to recruit B cells, local dendritic cells. You have an acceleration of a chronic inflammatory process that leads to a breach in your checks and balances on normal immunity. So you can get inflammatory arthritis, you can get vasculitic rashes, you can get regional lymphoma risks, right? So these are all different types of things that we think about. Cytokine overexpressions, cytokine storms that you might see from a cytokine release syndrome, really bad respiratory viral illnesses like the COVID-19 virus can produce, or even periodic fever syndromes, which are genetic. And then there's different types of immunoglobulin-mediated diseases. And these are some of your more classic rheumatic disease states, particularly like a glomerulonephritis would fall into this, your type 2 and type 3 hypersensitivity reactions. And then there's complement regulation issues. So all of these different types of theories kind of lead us to thinking about the normal function of the immune system, which is from the top left of the screen to the top right of the screen. So normally our immune system responsible for infection surveillance, right? And then tissue repair. Those are the two basic functions. That's what we tell patients all the time. And so if they're trying to discern whether their immune system's overactive with regard to their joint, I will say, hey, does it feel like you sprained it? Is it swollen? Is it boggy? Is it swelled up from like that inflammatory process? Or is it acting like it has a fever, infection? Because that's really what an inflamed joint will look like on the scale of an autoimmune disease. So normally our body will experience some kind of infection, or like it says here, a physical or chemical or mechanical stress. There'll be tissue injury, and our immune system moves through to clean it up and repair that. And so a limited disease, you have inflammation that is transient and that cleans itself up. But in the process of an autoimmune disorder, we have some type of dysregulation. And below, on the circle below, you can see different ways that this can breach. There's anything from like the effector cell activation not being as effective as it needs to, where you might get recruitment of dendritic cells that then present antigen in a prolonged stimulus, like we talked about with hepatitis C. You can have aberrant T cell activation, eventual B cell activation, produce autoantibodies, and that can proliferate that cycle. And so any of the possible therapeutic targets we have may look at some of these factors and ways that we can interrupt them. So over the years, we've slowly progressed with the things that we've offered as far as ways to suppress the immune system. So anti-metabolite therapy, alkylating agents, things that generically, like Big Hammer, impair cell synthesis and cell turnover. So by and large, you have risk of things like leukopenia and immunosuppression that occurs because of these. These are things like your methotrexates or azathioprine, or even alkylating agents like cyclophosphamide. About 25 years ago, biologic therapies came around. These are the formation of monoclonal antibodies that can hone in and very specifically target molecules like cytokines that help white blood cells communicate back and forth. And that's become the standard of care over time. That eventually developed into being able to target cells specifically and eliminate whole cell populations. CD20 cells, B cells, are targeted in rheumatoid arthritis, ANCA-associated vasculitis, but this was initially developed in B-cell lymphomas, right? So this is a drug that we have inherited from the hematology world, and that's a little bit of foreshadowing of where we're going, because we see a lot of overlap. It makes sense that the hematologic cancers and malignancies would have aberrant dysfunctions, and their therapeutics for targeting those would also provide immunosuppression in a way that would be beneficial for our patients. And then we've seen the development of other disruption of intracellular cascades as we understand these processes better, things like your JAK inhibitors, your TYK2 inhibitors. On the opposite side of that, there's also been monoclonal antibodies to help overstimulate the immune system. This is very different than immunosuppression. And I think this is a misconception sometimes with students and a lot of times with patients. They hear immunotherapy and they think about like our biologics that are immunosuppressive. But this is the opposite. It's checkpoint inhibitor therapy. It's stuff that is given to like a patient with a cancer to help increase survival rates by stimulating things like their T cells through either CTLA4 or PD-1. And it's really helpful in a rheumatology talk to talk about this stuff, because almost every one of these patients is going to have some form of immune-mediated adverse event, right? So you're talking about 3/4 of your patients having some type of autoimmune phenomenon because we're stimulating their immune system, right? Those types of things are going to be showing up with different types of endocrine disorders like pancreatitis, like diabetes, panhypopituitarism, adrenal insufficiency in some cases. But it can also show up in our clinics with inflammatory arthritis or colitis, sometimes like a pneumonitis. So it's interesting talking with different departments. Our colleagues in pulmonology have their interstitial lung boards or meetings regularly, and they're talking about the inflammatory pneumonitis they're seeing. Our friends over in GI are seeing ulcerative colitis, Crohn's presentations. And so as we stimulate the immune system and can turn it on to overact, we should be aware of these things too. So if you're seeing a patient, and you will at some point, who's on some form of immune checkpoint inhibitor therapy, have a high level of suspicion for an autoimmune type of reaction in those patients. Again, 3/4 of them will experience something, whether it's milder like a rash or as severe as something like an inflammatory bowel disease. So over time, we've been able to learn from the immune system, the protein structures that it offers and the cellular functions. And we've been able to harness that for therapeutic effects. So this is kind of a brief overview of the history of where things have gone over time, right? We have IVIG, where you have pooled donor gamma globulin that you can infuse for patients to have an anti-inflammatory effect. For years, we've been using the FAB portion of an antibody, which you see of an IgG molecule up at the top right. The effector aspect of this is that FAB with that light blue, right? That's your antigen binding fragment, as opposed to your crystallizable or constant fragment at the bottom, which is where your cells grab onto to help process the antigen presentation. we've been able to clip off the end part to use for things like digoxin toxicities, right? Like digibind and that type of thing over the years. So it's been something that's been out for years, but eventually they developed monoclonal antibodies to help target these specific cytokines. And this has been the mainstay of therapy in the rheumatology world since they developed it, probably about 25 years ago. But since then, there's been some more imagination as far as other ways that we can manipulate these molecules and develop other things like cell engagers, which we're going to talk about in a minute. And then even something exciting and new, like an antibody drug conjugate, where you use an antibody like this to target a very specific molecule in a cell, but then attach to it a drug payload that then delivers a drug very precisely to, per se, a tumor cell or something like this, which we'll talk about the mechanism of shortly. And then we've developed other things like cellular therapies over the years as well. And this is where we're leaning really heavily on our hematology friends, but we'll talk a little bit about the exciting world of CAR T therapies as well. So this graphic is really representative of a lot of different novel mechanisms that we're using to explore for drug therapies. Up in the top left cell, this is your bispecific T cell engager. Essentially, you have FAB units that are tagged together that help introduce different cell types to each other to facilitate an interaction. So like if you target CD3 on a T cell, and you also target a molecule that's expressed on your tumor cell, you could bring those two cells together via this linkage and facilitate the type of interaction that you want. We'll talk about that more in depth in a minute too. But the rest of this kind of shows all the different developments and exploration of different ways that these molecules can be manipulated and where some of the imagination is leading to breakthroughs in the science. So the bispecific T cell engagers are currently being used in the oncology world, and there are FDA-approved indications for this already. But again, the concept here, if you look at the top left corner with your T cells, CD3 positive T cell, you can develop an antibody that targets that, right? So we've developed that technology. You can use that to either eliminate or stimulate a T cell, right? That's similar to how your immunotherapy works that we talked about, right? Where you can stimulate CTLA-4, stimulate these T cells. You can similarly use an antibody to target a tumor cell if it expresses a reliable antigen on its surface. So if you take those FAB units in the center here, you can see them fused together to form what we call a BiTE antibody. And this will allow those cells to then bind together and facilitate that T cell interaction and engagement right where you want it to. There are different ways of doing this. You could also use like your typical IgG-like antibody, and sometimes we'll even see things like trispecific engagers, where this can actually bind to NK cells as well, or macrophages, to provide further interactions. The more interactions you provide, though, the less specific it gets, and so you run into other side effects. So most of the world of where they're doing T-cell engagers is in this bispecific mechanism. In fact, this drug already exists for the treatment of acute lymphoblastic leukemia. So again, you're taking an anti-CD3 monoclonal antibody and you chip off that FAB region, you fuse it to an anti-CD19, which targets certain types of B cells, and you can facilitate cytotoxic cell destruction of CD19 positive B cells, which works in acute lymphoblastic leukemia. As you guys know, CD20 therapies exist for us as well. We use these quite a bit. So there's a lot of interest in the rheumatology field currently in these bispecific T-cell engagers. And there's early studies going into looking at this stuff already. Here's that trispecific mechanism as well. And again, what you're seeing is a really similar type of interaction where you have a potential cell that has tumor-based antigen, you introduce your T cell to it, but then if you have an Fc receptor, the macrophages can get involved. Problem is though, if a macrophage gets involved and binds to just the T cell but doesn't bind to the tumor cell, what happens? Well, you can get transient leukopenias. You can start to kind of attack your T cells as well, which happens in some of these drugs. And so again, the more specific a mechanism, the less fallout you're going to have. And so that's the beauty of being able to manipulate antibodies for therapeutic indications. Antibody drug conjugates take this a step further in a slightly different direction, where you can actually fuse different drug payloads to that crystallizable portion of an immunoglobulin, right? So again, if you imagine a tumor cell or a tumor cluster that's expressing a specific antigen that you want to target, you can then infuse the patient with an antibody that will then carry the drug locally to that specific tumor cell. Some of that has a regional effect as those drugs break down a little bit. You can start to have a generalized area effect. They will then bind to the cell surface, and you'll start to actually activate those NK cells, similar to what we talked about because of the antibody cell interaction. But then also clarithromycin also will mediate endocytosis of these new drugs, right? So you can take something that will deliver something intracellularly to help target those tumor cells. They talk about this as a drug payload. I think our war language has gone a little bit too far when we talk about like targeting these things. They talk about like drug missiles, et cetera. But really the point is that they have high specificity for targeting what you need them to. Over time, as that breaks down, it can either target things like a microtubular polymerization. It can target cell synthesis through DNA disruption. And then as those cells lyse, they let that drug out. You can have a regional effect as well. So this is a new exciting area as far as drug targets. And there's some imagination going into how this would apply to rheumatology patients as well. We're not quite making that leap yet, but with the bispecific T-cell engagers, we are. But more recently, we've been seeing breakthroughs with cellular therapies. So if we take something like rituximab, which historically has really helped disrupt B cells, which help perpetuate that immune cycle that we talked about, we can also target maybe CD19 positive T cells. So the way that a CAR T therapy works is that they marry the ability of having antigen specificity with the cytotoxic potential of a T cell. T cells themselves have a hard time zoning in on a very specific antigen, but they're the heavy lifting of what the immune system can do. And so the whole point of this is you take, again, something like the FAB region of an antibody, and you try to introduce it into a T cell. So you can clip it off, and then you get a T cell co-stimulatory domain. You can then bind it with a CD3 molecule so that you get this chimeric antigen receptor. That's what this CAR stands for. Chimeric meaning it simultaneously has the antibody affinity, but the T cell domains of engagement. And then you can introduce this via lentivirus or other retroviral vectors to produce it within the patient's own cells. They then will proliferate, develop these CD19 positive CARs that will allow these cytotoxic T cells to then target the cells that you're looking for, right? So these are being used broadly in the hematology world, and more there's evolving evidence for their use in autoimmune diseases. It was initially developed with hopes that it would fight off HIV and be able to target certain viral vectors as well. Not really proven to be very helpful there, but it's being looked at other things such as lupus, scleroderma, ANCA-associated vasculitis, and then autoimmune muscle diseases. It's also being looked at for things like multiple sclerosis currently. And again, what you're trying to do is get your CAR T cells that have been developed to then bind to the target antigen, in this case, a CD19 positive B cell, to provide complete deep tissue penetration and elimination of the tumor antigen. And that's kind of the beauty of a CAR T cell in autoimmune disease. One of the trickier parts about using something like rituximab is that it doesn't necessarily hit all of the different types of B cells that you would maybe want to affect with long-term memory. So B cells, if you remember back to your immunology days, are responsible for things like plasmablasts and plasma cell formation, which makes our antibodies, right, long-term. Well, deep tissue memory, as far as the autoimmune response, maybe goes back a little bit deeper than just the things that the CD20 molecule hits. So the goal is to get a wide range of B cells that are involved with the CD19, anything from pro B cells all the way up to plasmablasts, to help really affect the patient's immune response. And then you get deep tissue penetration of these T cells. The process by which they go through to get this process is they do an apheresis or leukapheresis. So they collect the patient's own white blood cells or own T cells, and then they expose them to typically a viral-based transfection like we talked about. They introduce new DNA that allows them to produce these chimeric antigen receptors. They will then, in some platforms, expand them in the lab. Some platforms actually do so in the patient themselves, and they reinfuse, and that results in the targeted lysis. This is a good review article if any of you were looking for kind of an overview of how it works and how they're targeting things in autoimmune diseases. It jumps a little bit more into the details of the science behind it, and is really helpful. And again, this talks more about where we're headed as far as trying to treat the B cells at a deeper level. If you look here at the orange and the pink, the CD20 right here in the middle, across the middle, is where the rituximab effect will have. So you have a narrower range of B cell effects that maybe limit the degree of A, tissue penetration, and B, a long-term memory response. Rituximab, excellent game-changing therapy for things like ANCA vasculitis, right? It gets patients into remission, maintains their remission right now, but it isn't as effective for other things that we'd be hopeful for. Like we've had mixed results over the years in things like lupus. We've had mixed results in things like scleroderma. But over time, what we can see is that we're starting to get additional data showing that CAR T therapy actually helps sustain and induce a long-term remission in some of these patients. And this was kind of a landmark article that came out last summer, June of 2024, showing, this is my obligatory busy slide, but showing sustained improved remission without glucocorticoids, without immunosuppressive therapies, up to 18 months after the initial treatment with the CAR T therapies. This looks at 8 patients with systemic lupus, 3 with inflammatory myopathies, and 4 with diffuse cutaneous systemic sclerosis, notoriously difficult to treat diseases that were refractory in nature. Patients were all in what we call DORIS remission, which is a really strict remission criteria for lupus, a year and a half after therapy, essentially without steroids, without immunosuppression. We're seeing similar things in inflammatory myopathy in patients 9 through 11, and you see similar features in systemic sclerosis. And in fact, you see some improvement in some of their modified Rodnan skin scores. Some of these are fairly trivial within interoperator variability, but you see some of these with really sustained improvement in their modified Rodnan skin scores. But more importantly, they don't have any progression of disease in these studies. And so this is revolutionary. You know, I remember early on and thinking about these patients with diffuse cutaneous systemic sclerosis and thinking about this being somewhat irreversible. So we're starting to see some improvement in these patients and sustained improvement. So the question ultimately continues to be for us, like, what challenges exist in finding the right therapeutics, right? So from our end on the rheumatology side of things, we're always trying to make sure, like, do we have the correct disease classification? And these things evolve over time. You know, we think about things like our classification criteria for lupus nephritis, which probably is talking about multiple types of diseases and pathology simultaneously, which makes it really tricky to develop a therapeutic target. The more heterogeneity we see within a disease state, the harder it is to zone in on a really good therapeutic, and even harder to design a really good trial for it. And so evolving clarity on the etiology is going to be needed for most of our diseases. So again, most of that comes back to trying to understand that inflammatory process. And again, if we can pinpoint more specific mechanisms to disrupt this cycle, you can help facilitate limited disease and self-regulation again. And that's what the hope is with the CAR T therapies that we're doing. So I'd like to move on, kind of shift topics altogether and kind of move over towards more management. If any of you guys have questions, like informal, please raise your hand, just interrupt me, and we can start to talk a little bit more about it too, because this is kind of more of the granular, like hands-on patient stuff that we deal with regularly. When we talk about infections in our immunosuppressed patients, you know, there's a lot of misconceptions about how severe those infections are, how long they last, how to manage them when they're infected. Like one of the common calls we get from like the hospitalist side of things is when we have a patient that's on typically like an Enbrel or Humira, a TNF inhibitor, IL-6 inhibitor, who's hospitalized with sepsis secondary to UTI or a respiratory infection. They want to know, what do we do with the drug? And the answer is just hold it for now. And that's generally what we tell patients to do during the setting of infection. But in the back of our head, we're also wondering, okay, what's the risk of flare? What's the underlying disease state? What's the consequence of a flare-up, right? If you have a patient with rheumatoid arthritis, the consequence of a flare-up is probably just some inflammatory arthritis that you could treat with prednisone. But if they have really bad systemic lupus nephritis, we're just in the hospital last month with pulse dose steroids, mycophenolate induction therapy, you might not want to hold that medicine because it might still be early on. So these are things that we kind of adjust in our heads. But in general, if somebody has an inflammatory arthritis, which is the majority of our patients, rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, it's generally safe to hold those drugs for a little bit of time. Problem is there's really little data to support one way or another. Part of that's because there's a diversity of medicines that we use to suppress our immune systems. There's a diversity of diseases that we're treating. And so finding a general guideline is really fraught, you know, both in the scientific meetings, but also just based on the studies. So whenever we see a study that crops up, even if it's a limited study, we get a little bit more excited. And this is, I thought, was a pretty helpful study that the Infectious Disease Society of America did, where they took a group of patients, mostly these inflammatory arthritis patients, and studied them and said, hey, are they more likely to develop serious infections while they're on therapy? And if they hold their medicines, are they more likely to flare up? So patients here were patients that had grade 1 or grade 2 infections. So your clinical patients that you're seeing in clinic, they're not septic, they don't need to be admitted to the hospital, they're not being given IV antibiotic therapies. The question is, do any of them progress towards needing those things if we continue their DMARD or their biologic therapy, or is there any difference between them? And so they were able to enroll about 1,600 patients, and 474 of them had clinically relevant infections. And it's a really useful graphic, actually, just to kind of describe what we clinically see anecdotally in our clinics. And this is kind of how I counsel our patients too. They'll say, well, what's the likelihood that we're going to get an infection if we're on a methotrexate or a biologic therapy? And generally, as a rule of thumb, we say you're more likely to get an infection at a rate of about 30% increase, which I explained to them in my breakdown. I say, if you get 3 infections a year, a fourth is more likely, and they may linger a little bit more. But the reality is I can counsel them and say, it's really rare that I have a patient who has a really serious infection that's admitted to the hospital because of their biologic therapy. And the data kind of here shows that too. So grade 3 infections, which is, 2.1% of them, right, are going to be high enough where they're going to need parenteral antibiotics or hospitalization. And grade 4, where they have a life-threatening consequence or something that urgent evaluation is needed, right? Your septic patients, patients with end organ damage, that type of thing, is 0.1% of these infections. So again, we're talking about lower rates of the more severe complications, meaning generally like these biologic immunosuppressive therapies are safe and they're safe to use. And these are the type of infections that we would expect, and that's what the study showed. Most of them are going to be respiratory infections, right? And particularly viral respiratory infections seem to be at a higher rate. The study was done from 2020 to 2023, right in the peak of COVID. And so probably higher numbers distorted in towards the SARS-CoV-2 viral infections. But in general, they're at higher risk, which is going to inform some of our vaccine guidelines that we'll review in a little bit too. But generally, I think about UTIs and I think about respiratory infections. And sometimes you can get skin infections too. Your classic comorbidities for things like lower extremity edema, venous stasis ulcers still apply here as well. But other more rare types of infections don't seem to be increased either. And the outcome for most of these patients was that the patients who had disruption of the immunosuppressive medication while they were infected with clinically significant infection had very little outcome difference from those who had continuation of their immunosuppression. Got really wide confidence intervals here, but this is again a pilot study to kind of say, hey, is there viability here? One of the difficulties and limitations of this study is the fact that almost none of them go on to develop really severe infections. That's a great limitation to have, right? Like you don't want to see serious infection risks or acceleration of those infection risks. And similarly, patients also didn't have much in the way of flare-ups as they had continued their therapy or disrupted it. So really the study kind of shows us you can go either way, right? You can tell your patients one way or another, hey, like you're probably not likely to flare if you're well controlled, if you skip a dose or two of your Trexate or your biologic therapy. But also, if you take that through the course of your illness, you're probably not putting yourself at increased risk. I mean, we see this all the time with regards to patients who, didn't think to stop their methotrexate or their Humira, even though they're on an antibiotic for a respiratory infection or a UTI. And so really our outcomes kind of reinforce what we're seeing in our clinical practices. Another big question that we get clinically is how do we manage patients who have upcoming surgery when they're on a biologic therapy or an immunosuppressive therapy? And again, similar questions roll through the rheumatologist's mind as we're trying to counsel these patients. Is their disease well controlled, right? What disease do they have? How long has it been well controlled? What's the consequence of disrupting all their therapies? And so those things are different depending on their disease state. And that represents the heterogeneity, again, of what we see. Rheumatoid arthritis is different than an inflammatory myopathy. One is life-threatening, could result in hospitalization. The other is slowly progressive with long-term mortality and morbidity risks, right? So again, we're trying to manage those things based on the patient and what their disease states are. The other question is how quickly is the surgery needed, right? Do they need an nephrectomy because they have a malignancy? Or do they need a hip replacement, right? Can one be postponed versus another? So these things are in constant negotiation. And we talk about the risk of procedure, how immunosuppressive the medication is, and even what the half-life of those therapies are. And that leads us to some basic guidelines. And this is probably the most useful guideline that we see. This is from the American College of Rheumatology and the American Association of Hip and Knee Surgeons. They put out a guideline for hip and knee replacement therapies. So that's probably where the more robust data exists for these patients. And generally, they're updated about every 5 years because it's hard and slow to get data with regards to outcomes with these patients and infection risks, as well as surgical outcomes. But in general, we can continue all of their immunosuppressive DMARDs if they've got rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis throughout the entire surgery, meaning you don't have to hold a methotrexate leflunomide, et cetera, going through a surgical procedure. You may, these are guidelines too. Like a guideline's not an absolute. So if you know that a patient has had recurring infection risk or problems in the past, you might hold that depending on their risk of flare-up. But in general, a good rule of thumb is you always hold their biologics. And this is based on expert opinion without much in the way of data supporting it. But you'll see a common trend throughout this really busy graphic, which is to say you really want to hold it for the length of the infusion cycle or the injection cycle, which is about a half-life. So adalimumab, which is given every 2 weeks, you want them off their drug for at least 2 weeks before the surgery. And then you can restart it that week 3 or essentially, not restart at week 3. You want to do the surgery on week 3. Similarly, if they're giving an IV medication every 8 weeks, you want to do it the week after they would normally be due for their next infusion. It becomes trickier, though, when we talk about things that are dosed twice a year, like rituximab, where we might want to hold it until month 7. So we usually try to time the surgery, the elective surgery, if we can, to about the length of the infusion cycle for these patients. In the emerging world of using JAK inhibitors, which we're using more and more for varied indications, this is a drug that is in and out of the system pretty quick. Pretty short half-life. So usually we could actually do it. I usually tell my patients within a week, but you could actually go a little bit closer to surgery than that based on the dosing and the half-life of this. And again, this is a guideline that's helpful if you're all curious about it down the road. But that shifts depending on what disease they have. Again, we talked about the more severe diseases. And so really what these graphics and the tables get at for this guideline are to say risk manage these patients based on how severe their disease is, how active their lupus is, how long it's been under control. And we generally will extrapolate these to other life-threatening autoimmune diseases like your myopathies, your systemic sclerosis, your vasculitis patients. And in general, we're trying to say like, hey, if your lupus is rip-roaring and you were just in the hospital a month ago, like you don't get a hip replacement next month. We're going to try to put that off until you're in remission on a lower dose of steroids and try to risk manage that patient slightly differently and try to get them through palliatively until they can actually get in for that surgery. But if somebody had lupus nephritis 2 or 3 years ago is in clinical remission, we can start to hold their medicines. We can consider how to do that. And so there's some guidelines and approaches to that as well. But in general, what we're trying to do with these patients is say, how recently were they active? What's the risk of holding their drug? And then when do we consider counseling them and say, go for it, get the green light for that hip or knee replacement? A few other things that are really helpful to talk to with patients. We know that patients who have rheumatoid arthritis or similar autoimmune diseases have an increased hazard ratio versus those who don't for an infection, particularly prosthetic infections. And so that rate goes up a little bit. And it's not something that we try to discourage them from doing. I mean, a new hip, a new knee actually gives quite a bit of good benefit clinically with regards to their activity levels and quality of life. So we don't want to stand in the way of that, but we want to educate them to say, hey, you are at a little bit higher risk of infection. So let's walk through this. And often I'll just tell patients, reach out to us if you can't recall what we talked about. Let me know if you're going to have a surgery. The surgery that we don't care as much about is those cataract surgeries because there's such low risk of infection that we don't typically hold any of their immunosuppressive medicines through it. If they're having a joint replacement surgery, we talked about that a little bit already. They have a 30 to 5% risk of infection coming out of that surgery. Abdominal surgeries may be up to 10% risk, but part of that also has to do with like the extent of the surgery, the length of the surgery. A lot of these infections that occur aren't actually site infections from the surgical site or abdominal wounds or anything like that. Sometimes they're just pneumonias or UTIs that occur from the patient being immobile in bed on a ventilator. So again, general guidance approaching surgical interventions, we talk about whether the surgery is high risk or not. If it's not, we don't really hold the immunosuppression. I put dental surgeries in the same area too. People have like dental extractions, root canals. I don't usually counsel them to hold their antibiotic therapy unless, again, they've had a history of complications or if the dentist indicates they've already got an active infection. Typically, we'll just tell patients you hold a biologic drug for the half-life before elective surgery. DMARDs can usually be continued throughout orthopedic surgeries. If they're not orthopedic, though, we tend to hold them. And that's because that higher infection risk. And usually we hold a week before surgery if it's an oral DMARD. Again, any biologic we want to hold for a whole half-life. And we want to counsel them on the non-surgical site infection. So if a patient spikes a fever, we still need to look for like a UTI, right? So like if you see a patient on the ward who had a fracture, a hip pinning, et cetera, who is on one of these medications, right? You don't necessarily want to jump to assuming it's a surgical site infection. Still look to see if they got a pneumonia, still practice your good medicine, look for that UTI, et cetera. The risk is higher, again, with patients with rheumatic disease. And so we try to counsel them on that going into surgery. But again, we don't try to discourage the surgery if their disease is not life-threatening and if it's well controlled. So let's move into vaccine guidance, which is kind of our last topic. And this is something that is based on a few different sources. We have a few different things that we lean on, including the American College of Rheumatology guidelines, current CDC recommendations, and then the Infectious Disease Society of America really provide good insights and nuance into giving like a guideline for our patients. I know our nurses and clinicians get this set of questions all the time, which we're going to kind of dig into and go through. So here's a QR code again for the ACR guidelines for vaccinating patients with immunosuppression and disease. But really, it comes down to 5 different vaccinations that we want all patients who have a rheumatic disease to have if they're immunosuppressed. The first 3 are going to be your viral respiratory infections. And we really stress the annual influenza and COVID vaccinations with a point to say with the influenza, we never want you to get a live attenuated virus. So don't want to do the intranasal flu vaccine. Has anybody ever done the intranasal flu vaccine? Yeah, did it? Yeah, you did. Dr. Evans did too. Did it make you feel miserable? Yeah, it made me sick. I mean, it was awful. But again, it doesn't produce systemic illness, but it's a really robust stimulation of your immune system. But in general, we want to avoid that type of immunization when we think about our patients who are immunosuppressed because they might not be able to clear that virus. So it's more of a safety issue. We'll talk about what you need to do if you have to give a live vaccine in a minute, but we tell them, hey, get your annual updated flu vaccine, get your annual updated COVID vaccine. If you've not been vaccinated, we still recommend that multi-dose series based on CDC recommendations. And then we say, if you're over 50, get that RSV vaccine as well to help prevent that respiratory infection. So those are the 3 viral ones that we talk about for respiratory infections. But then we also stress a shingles vaccine and a pneumococcal vaccine. And this is for all patients, all ages who are immunosuppressed. And this is based on our guidelines and actually some of the CDC guidelines as well. So the Shingrix series is recommended at least once for patients. And if they've had the Zostavax years ago, which was a live viral vaccine, and it was a little bit of a tedious endeavor to get for our patients, because they're immunosuppressed, they can have waning titers. And so we still push them, hey, you should probably get that Shingrix vaccine so you can boost your immunity to this because it's much more enduring. If you practice long enough, or you've been around long enough, you've seen all these iterations of pneumococcal vaccines that will come and go. And I'm sure this guideline will change in 5 more years. But right now we're using the Prevnar 20 vaccine, which is a one-time dose vaccine. And the counseling that we're giving them based on the guidelines is say, hey, if you had Pneumovax 23 or Prevnar 13 or 15 in the past, you should still get this one as well. There's some nuance there. You can get a sequence of 2, but generally it's easier to tell them, get the Prevnar 20 and just be done with it for now. So in summary, we talk to patients and we try to summarize this pretty easily. And I give this on my patient handouts. You say, hey, you need at least one time to get Shingrix and Prevnar. And then if you're 50 or older, get that RSV vaccine to prevent the severity of that disease. And then yearly, we try to push through with flu and COVID. And sometimes we get beat up with conversations that patients want to have in clinic about whether it's safe or effective. And do you know the emerging evidence? And I said, you mean the emerging evidence that it reduces hospitalization, ER visits, intubation, death? Yes, I'm aware of that emerging evidence. Thank you. And then we try to encourage them to move forward with it. And the Infectious Disease Society of America actually provides some really good information with regard to that. There is data that patients don't respond as well if they're immunosuppressed to these vaccines. Right? We know that. So it's really helpful that we get these patients immunized before they start immunosuppression. A lot of these patients are on like an adalimumab or a rituximab or tocilizumab for months and months, years and years, and then they annually need to go get their vaccine. But what we know is that it still is somewhat effective. And even in this subset of patients, it does reduce the risk of those complications. So we say, yes, please go get your annual viral vaccines. And then sometimes we'll be asked, hey, do you need to hold the medication going into a vaccine? So generally the answer is no, don't do it, because the more hoops you make for a patient to jump through, by and large, the harder it will be for them to get their vaccine. So in general, and the guidelines actually support this, we were just talking about this before the lecture started, we tell people, get them all at once. Yes, like all 5 if you have to. You might have a sore arm, you might feel kind of crummy for a couple of days, but get your flu and COVID vaccine simultaneously. Don't hold your medicine going into it. But there is some data that suggests maybe holding methotrexate after an injection of influenza would be helpful. And same with prednisone. And so sometimes if you're on a higher dose of prednisone, greater than 20 milligrams, and this is good for internal medicine residents for boards, right? 20 milligrams is like your immunosuppressive dose of steroid, right? That's when we start to consider PJP prophylaxis, right? We start to think about other types of infectious risk associated with chronic prednisone use. Well, it makes sense that if your immune response is blunted, that maybe you would defer some of those long-lived vaccinations, like a pneumococcal vaccine or your zoster vaccine. But really, we want to decrease the curve every year. So you're still recommending that we give, and this is again a conditional recommendation, not high level of evidence, but we still try to push through. This is kind of standard of care in rheumatology. So regardless, we try to say, hey, give that influenza vaccine, and unless they're on greater than 20 milligrams of prednisone regularly, we try to defer some of those long-lived vaccinations. And in general, other live non-attenuated vaccines, we can continue things like methotrexate throughout, but there is some data that suggests that our response specifically to influenza is a little bit blunted if you're on methotrexate. So generally, if we run into it, we'll talk to a patient and say, hey, maybe we'll hold it a couple weeks after vaccination. This is a conditional recommendation though. And again, if you're talking to a patient who's like fastidious with regards to like how well they're going to check a box and have a list and get things done, then I will counsel them on this. But if I feel like, hey, the burden for them to like hold their medicine and time this out is just going to prevent them from getting their vaccine or take their medication reliably or appropriately, then I will still counsel them, hey, just keep taking it, because I don't want them to miss on either benefit. And then the rituximab is another one too. Again, if we're blunting B cell approaches or B cell responses that are again facilitating antibody development, there's thoughts that perhaps it would slow down the rate of vaccinate or responsiveness to the vaccination. And we tell those patients, hey, just continue your rituximab throughout. If we can, we want to try to time it, but who's getting their rituximab every year in like October and April, right? They may be getting it in July and January, right? So you can't really time it out to the end of their infusion cycle, and you certainly don't want to delay too much to get them their annual vaccines. And so that becomes a little bit more tedious. And then in general, we continue immunosuppressive medicines throughout for the other types of immunosuppressive medicines that we have when it comes to influenza or other non-live attenuated vaccines. But there's an important distinction that we should never give a patient who's immunosuppressed a live viral vaccine. And most adults don't really need this, right? Like there's not many occasions where we need to give a live viral vaccine. Several years ago, we were giving the Zostavax, which was a live attenuated zoster vaccine. And so we would have to kind of like take a little bit of a break and find a window to give it in. It was a pain. But nowadays we don't have a live virus vaccine for shingles. In fact, it's recommended that we continue on through that. But people have been asking more and more, what about the measles vaccine? And we're going to talk a little bit about why that might not be even a necessary discussion, although patients will continue to bring it up. What you're going to see here, though, is that in general, we have to hold for a good 4 weeks before you give a live viral vaccine and then 4 weeks after. So you're talking about like 2 months of the year without them being on therapy to try to get them a live viral vaccine, which again, pretty tedious. You risk the flare. And so we try to avoid those if able. These are questions we get all the time. Can I get multiple vaccinations simultaneously? Say, yes, please do. Please do it immediately. Go now. Please don't go home. Go get your vaccines. Because the minute they stop thinking about it, they might not get it, right? So we want to encourage compliance. And we actually will tell them the patients with rheumatic musculoskeletal disease patients, the recommendations, the guidelines say getting multiple vaccinations on the same day is preferred. And that's conditionally recommended mostly to lower the barrier for them to go get it, right? This is another common one I get all the time. My pharmacist told me I'm too young to get the shingles vaccine or pneumonia vaccine. Are you sure I can have this? I say, yes, and please have your pharmacist call me if they're concerned. I'd be happy to answer that question for them. We can guide them to the right resources to show them that these are guideline-based things. In fact, the CDC also says you can self-identify as immunosuppressed. You don't even have to have a letter from your doctor saying that you're immunosuppressed, right? So if a patient knows that their medicines are slowing down their immune system, that's an indication for the shingles vaccine, even if you're 20 years old. And pneumococcal vaccine also. And so we encourage them to go get those. Those are very strongly recommended. You can get shingles at any age. And then the other question we hear all the time is, I heard the CDC took away our COVID vaccines. Do I need a prescription? And the answer is right now, no. And this is pulled just from Sunday afternoon. I pulled this directly from their website and copied and pasted it. The CDC still recommends for immunocompromised patients that to go and get your yearly annual flu vaccine, or not flu vaccine, COVID vaccine, and that you do the multi-dose series. And again, you can self-confirm if you were moderately or severely immunocompromised. So for our patient population, they don't need a prescription to go get it. It's still available. They should go get it. Another point that we run into, and this is another question patient had, like, hey, I had COVID in August. How long do I have to wait? Do I have to wait 3 months before I can get my vaccine? The answer is no, you don't have to. You might have some coverage up for a few months afterwards, but you can get your vaccine the week after if you want to, 2 weeks after, a month after. But again, you may delay your vaccine for up to 3 months from the date that you had it because you probably have some transient immunity. Again, certain other things may lead you to get that vaccine sooner or later, such as like knowing that we're heading into that viral respiratory season, prior history of like interstitial lung disease, poor outcomes, you might want to have them go get it sooner. And again, local CDC COVID times and levels, which are not being accurately updated. So this is, again, a snapshot from Sunday afternoon. This site is updated on Fridays. Last updated September 26, 2025. So again, we're not really seeing good reporting, so it's hard to know what the incidence is to counsel them on that currently. So we try to stay with these guidelines and say, hey, this does reduce the risk of severity of the illness, et cetera. Please go get it. And then we get this one now too, which is I want to get my measles booster. Please? Please, but I want it. I want to feel good. No? Okay, how about the monkeypox vaccine? If there's no monkeypox vaccine, stop reading TikTok about what you should get and what you shouldn't get. And there's not really a good guideline right now for how we should approach this. And so there are some thoughts and theories with regards to expert consensus. But what's really helpful to understand about a second dose of a measles vaccine is that it's not really a booster, right? We're talking about a booster being something that's necessary to get you to like the required immune status. So this will increase the overall effectiveness from 93 to 97%. So it's really, you're not getting many gains on getting another booster. But it's also important for us to realize that US vaccination rates are varying wildly at this point in time, right? From state to state. So it's really important for us to know what our regional trends are, right? Like, do we have clusters of individuals who are largely unvaccinated? Like the state of Texas, right? Where more than 550 of these cases that were reported came from a small Mennonite community that was unvaccinated, right? These vary widely, again, regionally, like West Virginia, greater than 98% vaccination rate, where Idaho, we got less than 80%. So again, these things may come into how we counsel our patients down the road because this is expert consensus. We don't have good data on how to approach this. But in general, it's not wise for us to retest these IgG levels for patients. And mostly because we don't know what to do with that data or that information. The question is, are they even going to come into contact with an exposed individual or somebody who is ill, right? And if they do have low IgG levels, do I need to hold their drugs for 8 weeks while we vaccinate them for something that may not provide them additional benefit, right? There's more to immunity than just our IgG titers. Again, those long-lived plasmablasts may be able to respond to that infection, even if our titers aren't high. So there's no data that patients should be revaccinated. So in general, I'm trying to tell patients, hey, let's not chase those titers. Let's not hold your medicines to get you that booster because we don't know what we need to do. But let's say they work in a tight-knit Mennonite community or a tight-knit community of people who are unvaccinated. We may say, okay, for you, there might be an exception. And there's some quotes I threw up here. For the sake of time, I'm not going to read through them. But the gist here is that if there's a high risk of exposure based on a thorough infectious disease history, right? You're going to think through those patients and maybe suggest it, maybe consider it. But again, there's no hard and fast guideline. So it's a negotiation with your patient in those circumstances. But just doing as a blanket guideline is going to be really difficult to develop because it's going to be hard for us to develop data with regards to these things. And as Dr. Calabrese kind of notes, it just comes down to figuring out what their vaccine status is, what their natural immunity history is, and what their current risk is based on the community they live in. So this is how I'm currently counseling patients. I say, hey, I don't want to recheck your IgG level. What do we even do with that information if we get it? Should we hold your drug? How exposed are you? How much fear do you have? How can we treat that fear with more education, more information, rather than just responding with a lab test and giving you a vaccination that might not actually help you? If infection does occur, though, the treatment would be IVIG in the first 6 days to help boost their immunity and recovery rate. But unfortunately, there's no antivirals that exist for this. So again, I think about counseling our patients long-term. I'm thinking about their risk of stopping their medicines with regards to whether they have an infection or need a surgery, and then thinking about their vaccination status and how to encourage them to go get their vaccinations. Here's some key articles. I, again, tend to find these things to be really helpful to kind of walk away with. If you're interested in what the world of CAR T therapy is looking like in autoimmune disease, These are really good snapshot articles that will help you digest what that process looks like. Hopefully in the spring, we'll have Dr. Andrade come by and talk about CAR T therapies in depth and kind of give you the ins and outs, including things like cytokine release syndromes, et cetera. We'll leave that for him in the spring. But here's our vaccination guidelines and our surgery guidelines. And again, if you don't have access yet, if you're on Zoom or in the room, the USD library services and resources are awesome. Again, it's a really, really easy way to stay up to date on literature because it's all at your fingertips. They have a lot of other services, including things like research activity through the All of Us data set. They have different citation software and again, AI used data engines that we could use as well. So check them out. Thank you guys for participating in the lecture today. So do y'all have any questions?